So my name is Hannah Hesmedini. I'm a gastroenterologist. I work in the public system in Fiona Stanley, Osborne Park and Peel Health Campus, and also in private, mainly at Glengarry Hospital, but also occasionally at Hollywood and St. John of God Subiaco. So I'm talking about iron deficiency today. I hope that you guys enjoy it. I'm going to play it now. Hopefully it works. Just going to redo it. Here we go. Just to let you all know, good evening, everyone. I'm Hannah Hesmedini. I'm a gastroenterologist. Thank you for giving me the opportunity to do this presentation on iron deficiency. I welcome any questions or feedback.
It doesn't seem to be making, just sorry to interrupt, it doesn't seem to be making, you've got like a little thing in the corner and it doesn't seem to, there's no sound coming from it.
Okay, let's try. So did you hear the first slide or no? Okay,
no,
we'll just
it just had like, hello, I'm Hannah Hesmedini, and that was it basically.
Okay. Just to let you all know, this presentation is not designed to discuss iron deficiency in children, adolescents, and in pregnant. Iron deficiency affects a large proportion of the world's population, especially females of childbearing age. In all the studies to assess the scope of this problem, iron deficiency has been more prevalent than iron deficiency anemia, which is iron deficiency with associated low hemoglobin. And females are more affected than males. In a systematic analysis of the global burden of anemia from 1990 to 2010, they found the prevalence of iron deficiency anemia and anemia overall had decreased, but remained significant. For both the decades, virtually every population, including males, females, in all different regions of the world, iron deficiency accounted for the largest proportion of any cause of anemia. And for females, iron deficiency anemia was present in nearly 20,000 per 100,000 or 1 in 5 females. So what is iron deficiency or iron deficiency anemia? So anemia versus not anemia is based on the hemoglobin, and iron deficiency anemia is confirmed if the ferritin is less than 30 or in an inflammatory state where ESR or CRP is raised. There is a ferritin that's also raised due to inflammation, but there's associated reduced transferrin saturations or microcytosis on the full blood count. In terms of the risk factors and the causes of iron deficiency, there are 3 broad categories. Firstly, decreased dietary intake. Secondly, reduced absorption of iron. And thirdly, blood loss. It's safer to assume that the cause is blood loss until it's proven otherwise, especially in resource-rich countries like Australia. So with regards to bleeding, there's overt bleeding, which is usually not too difficult to elicit by history, such as traumatic bleeding, hematemesis, melena, hemoptysis, heavy menstrual bleeding, pregnancy and delivery, hematuria. But there are a couple of occasions that it can be easy to overlook, such as frequent blood donations, excessive diagnostic blood testing, or it can be easy to underestimate menstrual bleeding. In terms of occult bleeding, this is typically gastrointestinal, although hemolysis and urinary losses can be another cause. And in terms of the rate of gastrointestinal malignant lesions, as cause of iron deficiency. And there was a study of 9,024 adults, and in males and postmenopausal females with iron deficiency, the chance of identifying a gastrointestinal malignant lesion was 2% versus those without iron deficiency, which was 0.2%. Out of these 9,024, though, none of the females who were premenopausal with iron deficiency had any malignant GI causes. Next cause of iron deficiency might be related to reduced absorption. Iron is usually absorbed in the duodenum. However, certain conditions can interfere with normal iron absorption, such as celiac disease, as you're aware, and atrophic or autoimmune gastritis, Helicobacter infection, and also bariatric surgery, such as sleeve gastrectomies and Roux-en-Y gastric bypasses. But regardless of whether reduced iron absorption is suspected or documented, a bleeding source of iron deficiency needs to be excluded. In terms of adequate dietary intake as a cause of iron deficiency, as you're all aware, there is heme and non-heme iron. Heme iron is in animal products and is highest in the kidney of beef, liver of chicken, and beef. And non-heme iron can be found in fortified cereals, nuts, prune juice, and sunflower seeds. A recommended daily intake is different depending on amount of losses, but for women of a premenopausal age, a recommended daily intake is 19 milligrams per day, and a pregnant woman, a recommended daily intake is 27 milligrams per day, and for women of menopausal age and men, 8 milligrams per day. There are rarer causes of iron deficiency, for example, related to use of EPO agents for anemia related to renal failure and increased use of iron stores and redistribution, urinary or pulmonary hemosiderosis, or high-intensity athletes, as I mentioned before. With regards to causes of occult gastrointestinal bleeding that we find at endoscopy, there can be inflammatory or mechanical causes such as reflux ulcerative esophagitis, as seen in this picture here. Another inflammatory cause can be related to hiatus hernias with Cameron's lesions, as demonstrated in this slide. Another cause of occult bleeding can be related to peptic ulceration, gastric or duodenal, and also inflammatory bowel disease like ulcerative colitis and Crohn's disease, as shown in these pictures. Malignant lesions are the main ones that we worry about, and in this picture you can see a colonic cancer and also a gastric cancer on the lower picture. Vascular abnormalities such as angiodysplasias can be seen on patients with von Willebrand's disease or with aortic stenosis or other rheumatological problems, as demonstrated in these pictures. Gastric antral-vascular ectasia can be seen in patients with scleroderma, CREST syndrome, or chronic liver diseases. So in the next few slides, I wanted to discuss a few cases that have stuck in my mind to do with iron deficiency. So the first case is a 34-year-old mother of two, a 3-year-old and a 5-year-old, who presented with left-sided abdominal pain and feeling of a lump for the last 6 months. She was on a vegan diet. She was a non-smoker and had no other family history or medical problems. She was noted to have iron deficiency and mild anemia with a hemoglobin of around 100. She received an iron infusion, but there was recurrence of her iron deficiency 3 months following the iron infusion. She was then referred for a gastroscopy and colonoscopy, and she was found to have a transverse colon adenocarcinoma with liver metastases. The next case is a 35-year-old mother of one who's an 18-month-old. She was noted to have iron deficiency during pregnancy, had an iron infusion during pregnancy, and following the pregnancy, she had another iron infusion and recurrence of her iron deficiency, again, in spite of these 2 infusions. She was not on any other medications. She was a non-smoker and had no family history of any medical problems. She was also diagnosed with a sigmoid adenocarcinoma with liver metastases. So after discussing these 2 cases, and the reason why I wanted to bring them up is that there's a lot of contention in endoscopists if females with iron deficiency who are of premenopausal age should undergo endoscopy. As I had previously discussed in the large study of thousands of patients, there were no malignant cases in the premenopausal iron deficient patients, but at the same time, these do occur and can be devastating. And it's important to, if there are concerns about menorrhagia being the main cause, to keep monitoring and see if there's the degree of menorrhagia matches with the degree of iron deficiency, and especially in patients with iron deficiency anemia, rather than those with iron deficiency without anemia, I would have a very low threshold for endoscopy because better safe than sorry, in my personal opinion. The next 2 cases are 2 identical twins who are 24 years old. Both had recurrent iron deficiency without anemia, and both had required 4 to 5 iron infusions over the last 2 to 3 years. Their celiac serology was both elevated with a tissue transglutaminase of 160 in another one, and gastroscopy confirmed severe celiac disease, and this improved with a gluten-free diet. The next case was a 36-year-old female with recurrent iron deficiency in spite of repeat infusions for many, many years. She had a gastroscopy and colonoscopy, which were both normal. And I saw her in the rooms for consideration of a capsule endoscopy or further investigation of this iron deficiency. And it turned out that she has significant menorrhagia, which has been long-standing. She had been having 2 to 3 days of severe bleeding where she was unable to leave the house due to high risk of leakage. And a referral was made to a gynecologist, and this was able to be treated and her iron deficiency improved. The next case is a 61-year-old gentleman who presented with symptomatic anemia to emergency department in November 2019 with a hemoglobin of 55 and an undetectable ferritin. He was given blood transfusion and iron infusion and was discharged from the emergency department with GP follow-up, although I'm not sure what exact follow-up was recommended. He re-presented to the emergency department 6 months later in May 2020 with a hemoglobin of 55 and ferritin of 5. He was given a blood transfusion, and iron infusion again, and a CT abdomen was performed. And that showed that there was a mesenteric thick-walled irregular cavitatory lesion present, which appeared to be continuous with the small bowel and was considered for either a small bowel gastrointestinal stromal tumor or an adenocarcinoma, and there were also liver metastases present. And you can see this on the CT scan attached. Histology confirmed metastatic gastrointestinal stromal tumor. As you can see from these cases, there's a wide variety of causes of iron deficiency, from benign and treatable causes such as celiac disease to gynecological causes and also malignant causes. And the history is really, really important, and excluding a source of bleeding is very important prior to assuming that there's dietary or malabsorption issues. So with all of that, if I was seeing a patient with iron deficiency for the first time, this is what my approach would be. So it's really important to take a really, really good blood loss history. It doesn't have to be gastrointestinal or menorrhagia related. Sometimes people have recurrent epistaxis, or if they're on blood thinning medications, they can have recurrent cuts during manual work and bleeding, any kind of blood loss. And also taking a dietary history and also family history or personal history of any autoimmune conditions such as thyroid conditions, type 1 diabetes, can be associated with autoimmune gastritis or celiac disease, and also a family history of autoimmune conditions, but also, more importantly, any gastrointestinal cancers. In terms of investigations, I would do a full blood count to check the hemoglobin, check if there's macrocytosis or any other cytopenias, which might mean that anemia may be related to a marrow disorder. Kidney function to ensure that there's no renal failure and subsequent anemia due to that. Liver function test to make sure that there's no hemolysis as a baseline, and if there is any evidence of that on the full blood count, blood film, or liver function tests, further hemolysis screening can be done. CRP and ESR to check if there is raised inflammatory markers, such as in inflammatory bowel disease. Iron studies, B12 and folate, to check for any other nutritional deficiencies due to diet or malabsorptive condition. Celiac serology, obviously, to check for celiac disease, and anti-parietal cell anti-intrinsic factor antibody for autoimmune gastritis, and also H. pylori serology or urea breath test, depending on if the patient is on PPI therapy or not, to check for Helicobacter. The next stop, obviously, is endoscopy. So to start off with, gastroscopy and colonoscopy, unless something else such as a positive celiac serology has been identified. In gastroscopy, if endoscopically there is no cause such as a hiatus hernia, vascular lesion, or inflammatory lesion, antral and gastric body biopsies are usually performed for Helicobacter and also for autoimmune gastritis, and duodenal biopsies, obviously, for celiac disease. Colonoscopy is to exclude malignant lesions such as bowel cancer or any small bowel tumors in the terminal ileum, and then also inflammatory conditions such as inflammatory bowel disease, vascular lesions like angioectasias are also excluded. If the gastroscopy and colonoscopy are normal and there is no other obvious cause such as menorrhagia for the iron deficiency, and there is recurrent iron deficiency in spite of treatment, capsule endoscopy can be considered. This is to investigate for a small bowel lesion that can be vascular, such as angioectasias, neoplastic, or inflammatory. In addition to that, for the small bowel lesions, CT or MRI enterography, or even plain cross-sectional imaging of the CT of abdomen can be useful to exclude small bowel lesions such as gastrointestinal stromal tumors, like that patient we discussed earlier, or small bowel adenocarcinomas or other tumors. With regards to the treatment, regardless of presence of symptoms, all patients with iron deficiency anemia or iron deficiency without anemia should be treated. And the rationale behind this is the risk for further organ damage, ischemia, and progression of anemia unless the underlying cause of iron deficiency is addressed and adequate stores are replenished. This is with the exception where iron depletion is therapeutic. Polycythemia vera or porphyria cutanea tarda. Treatment can commence at the same time as the investigation for a cause of iron deficiency and doesn't need to be delayed. This can be via oral or IV routes. For milder cases without severe anemia, oral may be preferable, but efficacy can be limited by adherence and GI side effects. IV 1 gram infusion can be used in those with significant iron deficiency anemia and with those who are non-adherent or cannot tolerate the oral tablets of GI side effects, or those who have large volume ongoing bleeding, or those who have had a decrease in absorption. So my preference usually is to give a IV 1 gram infusion of iron carboxy maltose over a 15-minute infusion. I do discuss with patients the risk of a infusion reaction, which usually self-resolves without any specific treatment, but also less frequently a risk of an allergic reaction. And also obviously staining, although I have not personally experienced an allergic reaction or skin staining thus far. If the patient is reluctant to have an infusion for whatever reason, if they're needle phobic or they don't want to be in hospital, or they'd rather take tablets, we can trial oral iron first. I don't have any specific preferences, but I do discuss with them that they might have some GI side effects, and they might want to try a different brand of the iron if they prefer. And some people do find that they can tolerate certain brands more than others. However, if they are having intolerance issues or adherence issues, I would be quick to re-recommend an infusion, because that would reduce, that the iron has gone into the patient and is bypassing any adherence issues, absorption issues, or anything else that might be impairing the absorption. After the iron infusion, I usually recommend to my patients to have a blood test within a month of the iron infusion, and that's just to check how high the ferritin went and also what's happening with their hemoglobin. And it's good to have a baseline just after the iron infusion. And I usually read it 3 monthly. If their hemoglobin and ferritin remain stable at the 3-month follow-up, I may do another 3 monthly follow-up or 6 monthly, depending on the patient and the original degree of the iron deficiency, and go from there. With that, I'd like to conclude my presentation and welcome any questions that you might have with regards to iron deficiency.
So
I saw one.
Oh, yeah, there's a couple of questions in
I
there.
saw the question, one from Russell. So I don't think there's any specific guideline to say that you should do any kind of specific testing with regards to FOB testing with premenopausal women with iron deficiency. I'd be really careful about using fecal or cord blood, because it is designed for people without any symptoms, and iron deficiency is a symptom. So I wouldn't normally recommend that. In addition to that, I recently had a patient in Peel Health Campus who was referred for a colonoscopy with their altered bowel habit, which is usually a category 2 indication. And the GP had also done a fecal or cord blood test for whatever that was worth, and I had attached that to the referral, which was helpful. And the fecal cord blood test was negative. So that did, if it was positive, it would have been increased to a category 1 indication for a colonoscopy. And the patient did actually have a rectal cancer. So fecal cord blood test can definitely miss things, apart from polyps, obviously, even with cancer. And so I think the clinical picture and just assessing the degree of the menstrual loss, and trying to work out if that is adequate to explain the degree of iron deficiency is something like fecal or cord blood, which might falsely reassure. Does that kind of make sense, or what do you think about that, Russell? Okay, no worries. So there's another question about, is it necessary to check vitamin D and phosphate prior to infusion? How common is hypophosphatemia post-infusion and how to avoid it? I didn't know about vitamin D checks before an iron infusion. I've definitely never done that. I don't also routinely do phosphate prior to infusions. I know that with iron carboxy maltose or Ferinject, there is the risk of hypophosphatemia, which is pretty common, I think 30 to 50%, but none of these are clinically relevant. And I think that the hypophosphatemia that would be significant to the degree that would be clinical is exceeding. I've never seen it happen. I don't think there's any specific things to do prior or post to avoid it. But if it does happen to someone to a clinically relevant degree, then I guess you could try and check it before if you need to give them another infusion, and you could give them a phosphate infusion at the same time, but I've never had to deal with it yet after all the iron infusions that I've provided. Does that answer that question, or was there a specific incident that you wanted to discuss, Tanya? Have you guys experienced anyone having severe hypophosphatemia that required any treatment following iron carboxymaltose? Anyone?
Sometimes they're a little bit quiet. So if anyone wants to unmute themselves and then you can answer that question, or just put it in chat and we can read it from there.
Okay, that's interesting. Do you know how low the phosphate went for that medical colleague? I know from the days that I used to do liver transplant at Charlie's as a gastro trainee, we did have patients due to their like anti-rejection medication who had phosphates, but that were quite low. So unless they were 0.3 or lower, we wouldn't really consider them clinically relevant unless the patient had developed some specific symptoms. Okay, but we're not sure of the exact level. No. And how did it resolve in the end? Do you know? Oh, I see. Yeah, that does not sound good. Yeah, I'm not sure. Did they, for iron in the absence of anemia, would you suppose that? Yeah, I'm not really sure about the phosphate question. I would want to ideally know if they had any other risk factors like kidney impairment or any other medications that could have also doubled up as something else that could have caused low phosphate, but I've never seen it happen. But yeah, it is definitely to report it, but I think it's so rare that I've never had to specifically screen for it. And usually I haven't seen anyone who's needed treatment for it either. So I have another question about iron deficiency in the absence of anemia. Would you still proceed to endoscopy if no clear underlying cause? I think if you have iron deficiency without anemia, depends on what else is happening. So if they're iron deficient male, definitely would consider endoscopy. And postmenopausal females the same. If they had some other dietary things such as, you know, a vegan diet or whatever, depending on the degree. So if they had iron deficiency anemia, absolutely anyone would be needing to have at least baseline gastroscopy and colonoscopy, if not any further. But yeah, so if the degree is very mild, like a ferritin of 28 and they're on a vegan diet, yeah, that is probably explainable and doesn't need assessment. Is that a question?
I'm not sure if that's a question or not. I think so. Sometimes people
might be background noise.
Did someone just unmute themselves for a question? If not, you probably go on to which is the next one that you were doing? The elderly one?
The next question is, should all elderly in the nursing home be sent for iron studies? Oh, I don't know what the answer to that question is. Great question. Obviously, it all depends on what you're doing it for. So if I would have thought that it would be good as a nutritional basis to check for all their nutritional screening, especially like with, sorry, my
Oh,
chat
sorry.
screen disappeared.
Mhm.
No, that's all good. Especially to check that they're nutritionally replete. If they have, I'm thinking with nursing homes, they might have swallowing difficulties, they might not be adequately nourished, they might have lower appetites and might not eat certain things. So it'd be good in terms of that to do it. But if, depending on the reason why they're in a nursing home, I would consider if we're doing more harm than good by sending them for endoscopy as an investigation for their original iron deficiency. So, for example, if there's someone who is in a high-level care nursing home situation, they definitely would struggle with a bowel preparation for a colonoscopy, and it might be more harm than good. You wouldn't want someone to be trying to run to the toilet because they've got terrible diarrhea with their bowel prep and then breaking a hip for something that was very mild iron deficiency without anemia, for example. Or if to consider one step ahead. So if you did do a colonoscopy and they did have a bowel cancer, would that be suitable for treatment or surgery or whatever? So yes, bit of a general medicine question. So I think it would be good to check to replace as a nutritional value, but I'm not.
Could you just flip the old veggies? It'll be okay.
Pardon?
Yes, half an hour would be good, I guess. Sorry, I'm on Zoom.
I think someone might be accidentally unmuted.
Yes, I think so.
So did that answer your question about the elderly in the nursing homes checked for iron studies? Definitely anyone with anemia should be checked, definitely. And then there's a question about how long after an iron infusion do you advise patients to expect to feel a symptomatic improvement? Well, usually, so for patients without anemia, I'm not sure how much of a difference it makes in terms of symptoms, unless they originally had certain symptoms, and it should improve within a few days. But with patients with anemia, it's when their hemoglobin recovers, which is usually about 10 days, few weeks after an infusion, because obviously the bone marrow needs to turn the iron into red blood cells for them to improve in terms of their anemia symptoms. And that's the same thing with people who've had a blood transfusion in hospital, because the blood transfusion or the red blood cells from the transfusion will disappear over 7 to 10 days. So if they've not had iron replacement at the same time, they'll end up back in square one with iron deficiency and anemia. So even if they've had an iron infusion and blood transfusion and their hemoglobin is improved if they were originally iron deficient, or they've had blood loss. So for example, if they're in hospital with a bleeding duodenal ulcer or something, they definitely need to have an iron infusion as a catch-up dose. Otherwise they'll end up with iron deficiency. But most people with very mild iron deficiency without anemia, they don't seem to have any change in their symptoms after an iron infusion. Any other questions or comments on anything that I should have covered that I didn't?
So yeah, if anyone's got any questions, if not, we've got Dr. Harriento in the room as well. So there's one more question from Branka. And Hilman, if you want to share your screen, you can do that now.
So the question is, would you investigate a 90-year-old with mild dysphagia with no weight loss and ferritin of 30? Yes, I'd definitely investigate them, but not for necessarily the ferritin of 30, but more for the dysphagia. So first of all, it can be something very simple like reflux ulcerative esophagitis that can be treated, or it can be something like achalasia, which we frequently pick up in older ladies. And that is also treatable with Botox for more. So it's most likely that they might be developing iron deficiency if they've had difficulty swallowing, because they'll be avoiding probably the high iron foods because mostly they're chunky and meats. And so, yeah, I'd definitely refer them for a gastroscopy and then go from there, because that can improve their nutrition, their symptoms, and probably their iron deficiency as well. Thanks, everyone.
Excellent. Well, thank you very much, Hannah, and that was really interesting. So I'll get, hopefully Wendy will be back on board next week, and she'll send details over to you. And at the end of the talk, I'll get everyone to fill out the SurveyMonkey, and that will come back to you in about 2 weeks. So then if anyone's got any comments about future topics or whatever, they can put it in there as well.
Perfect. Thanks, everyone.
Okay.
Have a good evening.
Thank you. Thanks a lot. So are you there now? Can
you hear me? Can you see me or hear me?
I can see and hear you. Excellent. All
right, good. Trying to use this headphone, still never get used to this virtual presentation thing. All right.
So I'm just going to
mute myself
and.
Okay. Good evening, everyone. Thanks for joining me. Thanks for having me here. Let me see if that works. All right. So my name is Hilman. I'm one of the respiratory physicians, Hilman Haryanto. I work with CVS CRS and currently work in Netherlands, Midland, Liming, and Peel. I also work at Hollywood Private Hospital and Peel Health Campus and Mount Hospital. And I thought today I'm going to talk about the practical approach to respiratory inhalers, because there are recently quite a few new ones this year. And I thought it's not much in detail, it's more about a practical approach about which one to use and which order for which conditions. And I think, so just a bit of disclaimer, in the last 12 months, I've received speaking honoraria from GSK and Boehringer. And I think for this talk, for convenience sake, I will use brand names rather than generic names, because otherwise it will be very complicated and I don't think anyone will know what I'm talking about or which paper I'm talking about. I think because of the telehealth, the webinar nature, I think it's better to have questions at the end rather than during the talk, if that's all right with you guys, okay? So it's a bit of an outline what I'm going to talk today about the available inhalers, the current and the new inhalers, and the airway disease and diagnosis, and the type of inhaler devices, and the specific inhalers for COPD and emphysema, or inhalers for asthma, and new other inhalers. Okay, so as I think I'm sure everyone's well aware of this poster of all the available inhalers. All right, and there's recently an increased number of inhalers available, and there are also some inhalers that have actually been taken off now because it's not available anymore. And there are also new inhalers. Hold on a sec. As everyone knows, there's the Trimbo inhalers that's just recently available in the last few months. And also there are these other two new inhalers that's also recently available, but it's not much buzz about these two. These are the Atectura and the Enerzair Breezhaler. But I'll go about them in details as well, okay? So as we all know, the inhalers are used mostly for airway diseases. And this is really the only main indications for prescribing any inhalers. And as you all know as well, spirometry is key in diagnosing airway disease, along with clinical background history of childhood asthma, atopic history, smoking history especially, and any exacerbating factors. But still really, to diagnose any airway disease, you need to have a spirometry, especially to see if there's any airway obstructions where the FEV1 FVC ratio is less than the lower limit of normal. And asthma is described to be reversible airflow obstructions where there's significant FEV1 or FVC improvement post-bronchodilator by 12% and 200 ml. So you need to have those two criteria to have diagnosis of asthma. While COPD is actually a fixed airflow obstructions where there is no air bronchodilator response. Again, I think that's increasingly more commonly acknowledged now. There's often overlap in airway disease, which is asthma, COPD, overlap syndrome. And in that situation, it can be quite tricky to identify which one is more predominant. Is it the asthma or is it the COPD? And it's also important to remember that there are people with emphysema, but they have normal spirometry with no airflow obstructions, but they have a reductions in the gas transfer or the LCO, and that's what is normally done in comprehensive or full lung function tests. This diagram is just an illustration about what is gas transfer, which is essentially the efficacy or the effectiveness of the lung to exchange oxygens and carbon dioxide. And in the test, it's actually done by we use the carbon monoxides. And still, people with emphysema with normal spirometry with no airflow obstruction will still benefit, I think, with the use of inhalers. And these are the currently available inhaler devices. Now, these are the type of the device, which is the way the medications is delivered. So there are the pressurized metered dose inhalers. These are well known as the Ventolin. There's the breath metered dose inhaler, BMDI. Dry powder inhaler, these are the Ellipta device, the AccuHaler device, or the Turbihaler device. And the soft mist inhalers, and Respimat is the only one in this category, which is very unique, which release a soft mist rather than a fast metered dose inhaler. And I'll go through them again a bit more later on. Now, why is it important to get the inhaler devices correct? Up to 90% of Australians who use inhalers do not use their inhaler device correctly. And I'm sure you've seen that in your practice, that is actually quite true. But incorrect use of inhaler device is account up to 75% of poor control of airway disease. And it is best practice to check the technique at the start of prescribing inhaler and at least refresher once a year. But as we all know, practicality speaking, it is really difficult to actually check patients' inhaler technique due to time poor in the practice, and patients don't even bring their inhalers with them. So I understand that this is actually quite a challenge even with my practice as well, to actually check patients' inhaler in every visit. There are factors to consider when choosing the best inhaler device. I think it's better to choose more the right device rather than which medication that the device have. And also to check patients' compliance. Is it better to have once a day or twice a day inhalers? As general rule, all the MDI devices twice a day, and the dry powder device or soft mist device are once daily. And what's also really important, actually, the patient's ability to have forced inspirations, which what you need in the dry powder device, but not necessarily in the MDI device as well. And that can be done quickly at the bedside to ask them to take a deep breath like that. And if they can do it, and then generally can do okay with the dry powder device like Ellipta, AccuHaler, or the Turbihaler. Now, I'll bring back these slides. I just about my anecdotal about which one is the best or the worst inhaler devices. In my experience, I think really the worst device is the pressurized metered dose inhaler, though it is the most common one. But generally, it is really difficult, I think, to coordinate, to press and inhale at the same time, because technically you need to inhale first, just a split second before you press it. Compared to other one, which is the would rely on patients' forced inhalations, essentially it doesn't need as much coordinations. But I do think the best inhaler still, actually the pressurized metered dose inhaler, if it's used with spacer. So the technicality challenge with the MDI device, I think is quite eliminated quite nicely if the patients use a spacer. But as we all know as well, the problem with the spacer is that it's bulky, and patient can deter patient of using it regularly because they don't like to bring it around. But I always say that for them to have the spacer on the bedside that they can use it regularly, and if they need to bring it around, then they can use the MDI without spacer. But yeah, but I think all the other inhalers are also really good if they can use it well. So really, the worst inhaler, I think, is the MDI if not used properly, but the best inhalers are all inhalers if they can be done properly. Just a bit of a segue about the news recently. I'm sure some of you might know that the Philip Morris, which is the largest tobacco company in the world, is actually buying Factura, which is a company in the UK that is producing inhaler devices. They actually produce the Ellipta device, They produce some other devices for Novartis as well. So this is actually big news in the respiratory community. And we, of course, we condemned it. We're not sure what they're trying to do. We think that they're trying to deliver a way of tobacco through the inhaler device. But yeah, watch this space, I guess. I think that's not a very good thing for them to do. Anyway, a bit of another segue as well from that, speaking about smoking. What is the most effective treatment in airway disease? But actually, it's not inhalers, as we all know, it's the smoking cessations. Smoking cessations alone can reduce patient symptoms by 75%. And I don't think there's any other treatment pharmacologically that can actually have that much impact in patients' airway disease. So just be a reminder that smoking cessation is still the most important in management of patients' airway disease, if they're still smoking, of course. Now, we're gonna go talk about the inhalers for COPD. The picture there on the right, that is from the local guidelines, which is the COPDX. To summarize, so the practical approach of the COPD inhalers to me, if you find that someone with COPD, confirm on spirometry, what I would start with is a LAMA. If they have exacerbations, such as or requiring 2 antibiotics in 12 months, then I think I will add a LAMA and LABA combinations. If they have further exacerbations in 12 months with requiring another antibiotic or exacerbations, even if it's non-infective, with requiring steroid as well, then I'll step up to LAMA, LABA, and ICS. So the definition of exacerbation is either 2 episodes in the community requiring step up in or any additional pharmacotherapy, such as antibiotic or steroid, or one hospitalization exacerbation. So that's a serious exacerbations. All right, so that's a step up there I would do. Theoretically, by the guideline, to start off with, you can start with a LAMA or a LABA. But the study has shown actually LAMA is actually some slight better efficacy in the patient with COPD, in mild COPD, in terms of managing their symptoms and reducing the further exacerbation. So in that sense, a lot of us in respiratory world, we would start with a LAMA first. That's what we do. LAMA first, LAMA, LABA, and then LAMA, LABA, ICS. Again, just to highlight in terms of the inhalers that is available, go back, for the COPD. The one that is red is highlighted. These are the new one that is recently available in the formulations, which is the triple therapy or trilogy. This one is not that new anymore. That's available since the last year or two. But what's new since June this year is Trimbo, which is a triple therapy indicated for COPD. And Trimbo compared to trilogy is twice a day formulations. And the difference with Trimbo is that compared to trilogy, again, like it says twice a day, but it's the same company that makes with Alvesco, which is Chiesi, and they always try to make their formulations to be small particles that can go to small airway, which I will talk about it later in the ASPA component. But this actually is giving us patients a lot of more options, I guess, in terms of the triple therapy. Now, like I said, triple therapy for COPD is more for moderate or moderately severe patient with COPD, which keep on progressing despite the initial therapy with LAMA or LAMA, LABA. This slide just to remind everyone that ICS works with the LAMA and LABA, it also has a synergistic effect with LAMA and LABA. So ICS will work. So inhaled corticosteroid will work people with COPD, will definitely improve their symptoms, reduces their exacerbations risks, and also improve their mortality in that sense if they have respiratory exacerbations. But the problem with COPD, we like to use it as last in people, ICS to be used last in people with COPD or emphysema, because the study has shown that there's a small increased risk of pneumonia. I must stress as well, though there's a very small increased risk of pneumonia, but the study only showed in one type of ICS, which is the fluticasone furoate, which is the one in the Ellipta device, like Trilogy or the Brio. It's not been shown or shown in any other type of ICS. Also, keep in mind that the risk of pneumonia is actually quite mild. So it's not serious pneumonia. This is mild pneumonia that can be managed within community. But even though there's a slight risk in case of pneumonia, that's why we would like to use it last in COPD. We wouldn't like to use it at the beginning for people with COPD. This is a triple therapy in COPD, like I said, but currently available. Trilogy Ellipta, as we all know, which once a day. Trimbo, which is 2 puff twice a day. I'm not sure why I chose the one with the Russian box there. There is another one coming out soon. When I say soon, probably by the first quarter of next year. There's another triple therapy inhalers that's coming out from early next year, which watch this space, I guess, but it's definitely is coming under the TGA. Essentially, it will be twice a day formulation as well, 2 puff twice a day like Trimbo, and will be like an MDI as well. Again, which one is better? There is no head-to-head comparison, so really there is no reason to know which one is better or not. I think what's important is to try it. Now we'll go to the inhalers for asthma. Again, in terms of my practical approach with people with diagnosis of asthma when it's confirmed on spirometry and clinical history, the first start to people with asthma is RCS and LABA right away, not RCS alone. RCS LABA as required. So again, we use RCS LABA as required. If the patient have improved progression of the disease, RCS LABA as required is not sick. It has definitely progression on RCS LABA in terms of symptoms. Then I'll start with RCS LABA as maintenance, which is twice a day, and a reliever. Now, to be practical about it, the RCS LABA PRN as required, that has been proven in the evidence-wise is actually the Symbicort Turbihaler, not the Symbicort Epihaler. That's the study have shown only Symbicort Turbihaler. But we in a respiratory also try to use Symbicort Epihaler as required and also as maintenance and reliever as well, because the idea is that it's the same medication that it should work as well, depending if what preference the patients use in terms of the inhaler device. Now, point number 3 is RCS LABA and RCS. This is the dual RCS or double up on the RCS with the asthma. Sometimes we do that in the people with asthma, and we think that there is the use for more RCS. I'll talk a bit more later on. And only at the last resort, when the patient is definitely progressing despite a lot of RCS, we go with RCS, LABA, and LAMA. The key point from here is that the mainstay treatment for asthma is RCS. RCS. Steroids, that's the one that works. Okay, it's not the LABA, not LAMA, but it's the steroid that's the main component for the treatment for asthma. Again, this is the picture for all the available RCS and for asthma. And I highlighted the new ones, which is relatively new, is the Arnuity Ellipta, which is RCS only, which is an Ellipta device. This is a once-a-day formulations. Foster, that's recently available as well, but about what, March or April this year. Trilogy, I highlighted Trilogy here because right now the Trilogy is only indicated for COPD, but they are coming with a Trilogy indication for asthma with a higher dose of the steroid. Instead of 100, it will be a 100 microgram of fluticasone furoate, it will be a 200 microgram. The other two that's new, like I said, is the Atectura Breezhaler and Enerzair Breezhaler. Now, these are both once a day formulations, and these are the dry powder. All right. To be honest, right now, I think the Breezhaler is getting out of favor because of convenience sake, because patients still need to bring the capsule and put it into the device, need to bring it around and then inhale it, while the other devices, you don't need to put a capsule into it. But some patients still do like to see the capsule, to see the medications dispensed, and there's no more left medications in the capsule at the end every time they use it, so they know that's getting there. Now, a bit more nuances or insight about inhaled corticosteroid. Like I say, it's the mainstay treatment for asthma. These are the few types of asthma. I know I said I would like to go with the brand name, but I will go into the generic name for it. Beclomethasone is the oldest type of RCS. It's the first one being invented. It's currently available in Cuba And also that's the one in Foster. Foster is different because, well, the company described that they formulated as to be a smaller particles and go into the deeper part of the lungs. After that, the second oldest will be budesonide, which are all familiar with this, with Symbicort. Symbicort Tropicella, Symbicort Rapihella, Duoref Spiromax, and Pulmicort. Okay. Next is the cyclesonide, Alvesco. Alvesco is its own formulation. There is not formulation with any other LABA. And typically this is the inhaler or the ICS that we use to double up on people with asthma. Next will be a fluticasone propionate. This is not that, would be probably the second newest type of ICS, which is the Seretide and Flixitide. The newest form of ICS will be the fluticasone furoate, and this has exclusively come in the Ellipta device, exclusively produced by GSK, and these are usually once-a-day formulations. As the newer steroid, they have a better glucocorticoid receptor affinity, as you can see, and this from the slide, the newest one, which is fluticasone furoate, has the highest glucocorticoid receptor affinity in vitro. This is in the lab settings, okay? How is that reflected in the practical settings? Well, the company would say that that's why the fluticasone furoate lasts longer, so there's only once-a-day formulations. They would say that it's also more specific to the airway glucocorticoid receptor, therefore there is less systemic side effects. They would say that therefore that is the best one. Well, and they also have shown study that fluticasone, stay throughout 24 hours and they have significant response or significant positive in terms of spirometry response as well. There have been study that's been published. But what I would say to that is, I guess, yes, fluticasone is the newest, furoate is the newest one, but it depends on what patients experience as well. I would still try with the patients, if they tried sometimes the patients coming to me with the Ellipta device or the fluticasone furoate, they say that, it works well in the morning, but in the nighttime, I don't feel the effect as much. And when I try to change to the twice-a-day formulations of ICS, and they feel like, okay, you know what, it works better. I like that better. So that's why I think it's more about patients' preference and what they try, what they like to begin with. It's more a bit of a trial as well. Of note, there are only 2 types of ICS in WHO list of essential medicines. It's just an interesting segue as well, which is the beclomethasone, which is the oldest type of ICS, and budesonide. But keep in mind as well, these 2 types of ICS are already out of patent, so that's why there's a lot of different companies that can produce them too. But yeah, these are, interestingly, the 2 types of ICS that are listed in essential medicine. And recently as well, budesonide, which is the Pulmicort, is probably the cheapest effective COVID treatment that's been proven. In the UK, they have released published evidence in Nature or Lancet Respiratory Medicines that people with mild or moderate COVID would start with Pulmicort right away or budesonide with 200 microgram dose actually have reduced their hospitalizations. And this has been initiated as well in India during the recent COVID outbreak. And it's probably the cheapest COVID treatment that we have to date. So that's the other interesting point about budesonide. Interestingly, that didn't show any benefit in people with COPD or emphysema. It's more for people who are budesonide naive in COVID. So that's another interesting fact, I guess, about recently. Now, again, the key point with inhalers for asthma is that there is really not much role as ICS alone as a reliever or preventer now. The evidence have shown that really if you have the patient with asthma, start with ICS LABA right away as a PRN dose. That could be a Symbicort Rapihella, Symbicort Tropicella, or you can actually use Foster as well, though it's not actually being PPS indicated for it. PPS indication for Foster is only for maintenance only, so only for preventer only, but I have actually been prescribing it as a reliever as well. Yes, but it has been used, Foster has been used in the UK for a lot longer than here in Australia, and has been used as a maintenance and reliever as well. I talk about the double up of the ICS now. That's actually because of the concept of small airway disease. Small airway disease, essentially, the thinking is that asthma that can have a large airway, which is a central airway, or the small airway, which is a deeper part of the airway. Now, this is a bit of nuances that you can see on some of the spirometry. Some spirometry release the number, which is the FEF 50% or 75%. So as I say, usually the definition of asthma when there is significant improvement in the FEV1 or FVC by 12% and 200 mils. But sometimes you see a patient with asthma and then you see the FEV and FVC is improved, great. But if you look at the FEF 50% or 75%, that is actually increased by a lot more than the FEV1 or FVC. That's for us indicating of, all right, this could be, there's a small airway disease component, all right? And usually, if there's a patient with small airway, they usually have a large airway disease as well. And these are when we double up on the ICS. So for example, they're already on Symbicort, for example. And that's when I would add Alvesco as an ICS as well. Or they're already on Seretide, then I would change to Foster. So the two ICS that is formulated thought to be better for small airway are the Foster and Alvesco. Now keep in mind, these are all in vitro, so all based that are in the lab. But whether there is actually any clinical relevance, there's no real study comparison for it. And like I said before, triple therapy for asthma is rarely prescribed now, only at the last end. Okay. So my tips, I guess, which inhalers are good? Well, I guess any inhalers that patients use correctly and regularly. Because I think by the end of the day, if you got any of the inhalers medication in their lung, that's better, rather than if they're not using it correctly or they're not using it appropriately. I think that brings the end to my presentations. If you have any questions, I'm happy to answer them.
Harianto, that was brilliant. Is there anything in chat? Yep, there's one in chat. Can you read chat?
Yes, I can read chat.
Yeah.
So the question is, are the dry powder inhaler devices fairly equivalent, or is there a superior device? All right, so I guess the question is whether is the dry powder inhaler, is it good? So I think it is good if it is used properly, but keep in mind that dry powder, usually they're quite large particles. So actually, a lot of patients often describe that they get stuck inside their throat. And that's what they feel, that's what deters the patients to use them. The best example of that is actually the Bretaris device, the Genuair device. That one's particularly quite powdery, and it's actually a dry powder device. So that's the problem with a dry powder device. Though generally, like I say, like the Ellipta device, which is dry powder, which is the Trilogy, Brio, they are quite small particles really, and they actually, patients don't describe that they're actually stuck inside the lung, and that generally looks better. So, but that's why I don't particularly like the, the Enerzair Breezhaler device, because they're generally large particle as well. A lot of patients, my experience actually describe a lot of these powdery sensations to deter them of using it. Okay. All right, the next questions here. Any thoughts on the potential impact of the possible Vectura takeover by PMI, which is the Philip Morris International, implication for PBS and prescribing in Australia? Yes, that is very, us in the respiratory community is very watching that space very closely, and we are definitely condemning it. And I think because of that, the takeover has been quite delayed or not as straightforward. I don't think they're officially taking over. They released a statement to takeover in June, I believe, but then that has not been formalized as well at this moment. The Vectura is a third-party device, that a company that produced devices for different companies. So they actually produced the Ellipta device, they produced for Novartis as well. I don't know if that's actually impacted on the devices that they produce, but I think there's more, they're gonna come up with a new device that has more tobacco in it. So I'm not sure what the potential implication it has on PBS and prescribing in Australia, but I guess we just have to watch this space And us in TSA Angel as well as closing this page, that space closely. Okay, next question is, should we still be using Seretide with the newer less side effects inhalers such as Foster? I think that's a good question. There are patients that's been using Seretide for quite a while. And if they're using it for quite a while, if they come to me, they've been using Seretide for quite a while, and they say, do you have any, they have no problem with it, they're compliant with it, then I wouldn't change it. But it's true anecdotally, in my approach, that it will not be my first preference for if prescribing for the first time for Seretide. For generally, I would prescribe Symbicort for people with asthma to begin with, or Foster. Again, I'm not using it because I'm not saying this brand because I've been paid by drug company, but it's just my clinical practice. The next question is, did you say that in COPD we should not prescribe ICS, or I got it wrong? So what I'm saying, in COPD, we should prescribe ICS at the last resort. You shouldn't prescribe ICS to begin with. To start off with, you should prescribe is LAMA, and then after that is LAMA-LABA. And if the patients still have more exacerbations, then yes, triple therapy, LAMA-LABA and ICS. Now, I didn't touch into this, but the other reason while I don't like ICS in people with COPD as well, now the other lung disease that I didn't touch is actually bronchiectasis. In people with bronchiectasis, particularly, I do not like to prescribe ICS first off. I only prescribe it as a last resort if you really need to, because like I said, about the potential risk of increase in pneumonia, and also there is some study that show increased risk in Mycobacterium or non-tuberculous Mycobacteria in people with bronchiectasis because they have a lot of phlegm accumulations. So that's another population as well that I would not like to prescribe ICS first off. Again, like I said, a lot of people with airway disease, actually a lot of overlap. Asthma, COPD, bronchiectasis, and so on. So that's why it can be a bit tricky to find out which one is the more predominant features. All right, next question is there any role for cromolins and Montelukast in asthmatics? In terms of Montelukast and cromolins, in adult population, it hasn't been shown to be as effective. But again, on the other side, I don't think there is much side effects for it. So I still do prescribe Montelukast, but not as first off. I will prescribe ICS and ICS-LABA. And then after that, there's still, and then double LABA ICS and they have issue, then I will add Montelukast as well. But again, I don't think there's any wrong in trying them as well. Okay. Same with the cromolins too. Next question is just to confirm, did you say that in asthma, instead of starting with ICS and then stepping up if necessary to ICS-LABA, just go straight for ICS-LABA? Yes, so in asthma, if you have definitely diagnosis of asthma, I'll go with ICS-LABA as required first. ICS-LABA PRN, if they're really mild, or only if they're symptomatic intermittently, then ICS-LABA PRN. You can go straight to it. That's the evidence, that's the best evidence, and that's actually showed it's actually modify the disease in the future as well. And that is actually PPS definition too. All right, just go straight to ICS-LABA as required. If the symptoms getting worse and worse, then definitely ICS-LABA regularly. So bring back the next question as well. Do you still use SABA PRN in asthma, or are you using ICS-LABA only as PRN? So if I'm confident with the diagnosis of asthma right away with the spirometry and clinical picture, definitely there's bronchodilator reversibility, no smoking history, then I would still go ICS-LABA right away as PRN, yes. Yes, unless it's really, really mild, then you can say that you can try this SABA only, but definitely with asthma, I think definitely go to ICS-LABA only, even as PRN. And that has, yeah, like I said, been shown to cause disease modifications and preventions of worsening of the asthma to become fixed airflow obstruction in the future. That's the reason why we want to go aggressive with people with asthma, because if not treated in the future, it can be fixed airflow obstructions like COPD or asthma, emphysema, which not gonna respond as much to the inhalers. Hopefully that answered a question, and hopefully that answered the questions clearly. Any other questions? There's another question. What's your preference, Seretide or Symbicort if using ICS-LABA PRN? Symbicort, because that's where the evidence is. The study that show maintenance and reliever for asthma, for ICS-LABA, is Symbicort. There's no study in serotype. So I will use the Symbicort, either Tropiheller or Rapiheller. The other one that I will also potentially use is Foster as well. Again, as ICS-LABA PRN. Okay. The next question is about, what about acute exacerbations in asthma who are needing frequent PRN medications? Still use ICS-LABA or SABA in this case? So about acute exacerbation in asthma, so definitely use ICS-LABA first. What I would tell them is after half an hour, then if there's not helping, then definitely can use SABA. So the point is to use ICS-LABA first, but they can still use the Ventolin as well, because you cannot use ICS-LABA as frequently as much as the SABA or the Ventolin. So the maximum dose of ICS-LABA, which is 2 puffs up to 5 times a day, so 10 puffs in a day. They cannot use any more than that because there is a lot of ICS otherwise. Okay, so definitely can use ICS-LABA and tell them if after half an hour the symptoms is not improved, definitely use the Ventolin or the Atrovent because it's only short-acting dose. All right. Hopefully I've answered all the questions correctly. If any other questions?
So yeah, if anyone's got any questions, and in the meantime, I'll just put the QR code up for just for the SurveyMonkey. So thank you very much, Dr. Haryanto. That was very interesting. And